Hi everyone, I'm Scott Taylor. I'm the CEO and co-founder of Perks Health. Looking forward to this session today. We're really thrilled to have you join us. We're talking today about how technology companies are transforming care for older adults, and we're very fortunate to have Dr. Mike Cantor with us. I'm sure if you're like me, you have many, many questions to ask, particularly if this is something you spend a lot of time thinking about day in, day out. We will have questions submitted via the chat, and then at the end of the session, we'll pull a few of those questions up. But to introduce our guest, Dr. Mike Cantor has been deeply involved with the care of our older adults through the course of his career. He's been a practicing geriatrician, making house calls, to then working as a medical director at United Healthcare, and now holding chief medical officer roles recently at Bright Health, Uber Health, and Intuition Robotics. It's safe to say he has got a lot of experience in this space and has very much helped shape the evolution of care of our older adults over the course of his career. So just want to say a big thank you for joining us, Mike.
You're welcome. Great to be with you, Scott. Looking forward to this conversation.
Fantastic. Well, first, before we dive into specifics and the technology related questions, I'd love to get a bit of an understanding of what initially inspired you to focus on specializing in older patients and care for older patients, and how kind of your then subsequent experience and kind of working with technology companies has shaped the way that you approach that care for older adults.
Sure. So I became interested in working with older adults when I was a resident. I live in Boston and Beth Israel. I was fortunate enough to have my first attending when I was working in the hospital was the chief of geriatrics. And he noticed that I really enjoyed working with older patients. And I've always been interested. I'm a lawyer as well as a physician. I've always been interested in areas where law and medicine intersect that don't involve malpractice. And so policy issues, ethics. And he said to me, the questions of how our society is going to allocate resources, how we're going to manage care at the end of life. These questions are so important in the care of older adults, and you like working with them as a group and you enjoy, these are the questions that you're really passionate about. It's a great option to go into this field, especially because we're going to need more geriatricians in the future as our population continues to age. And so that's why I got hooked on geriatrics. And I've been lucky to practice in lots of different settings. I worked in hospitals, I've made house calls, as you mentioned. I've worked in outpatient clinics as a geriatrics fellow. I went around the world, including to Australia, to look at how other countries take care of older adults in the community. And you see that there are a lot of commonalities. The problems and the challenges of aging are the same for all of us all over the world. But each person is unique. Each person is a little bit different. Each person has their own family, their own community, their own story. And so, what's great about geriatrics is the need to think about population level challenges, like how we're going to manage the growing number of people who have cognitive impairment, or how we're going to prevent falls, how are we going to work to keep people healthy. But no matter what you do at the population level, ultimately for each of us, it has to be made personal. And it's very much an approach to care which is holistic. The definition of health is not the absence of disease. It's good nutrition, it's growth, it's engaging with community, it's basic things like food and shelter and having the opportunity to communicate with people on a regular basis and feeling part of a community, not isolated. And so that holistic approach to successful aging has always been really interesting. And in terms of technologies, what's also really clear is that as we get older, many of us are going to need help. We're going to need more help getting from place to place with transportation. We're going to need help with taking our medications properly. We need help, thinking through like how am I going to manage my health problems and not let them keep me from doing the things that I want to do. In our world in the United States, that help is getting harder to find. Certainly in professionals who work with older people, the number of geriatricians is shrinking as many of us retire. At a time when we need more of us, there are fewer of us. The same is true for nurses who specialize in aged care. Same is true for physical therapy, for psychology, for all of the health disciplines. We face a serious workforce shortage when it comes to people who are experts in and actively enjoy caring for older adults. As a caregiver, I'm lucky. My mom's 89. She lives in Kansas City in a nursing home. My two brothers and my sister and I support her and have for many years. And so, on the non-professional side of caregiving, there's also this challenge of there are fewer and fewer of us who are able to take care of those in our society who are kids and those who are older adults and need help. In fact, if you look at the statistics, the dependency ratio, which is basically if you add up the population under 15 and the population over 65, and you divide that by the number of people between the ages of 15 and 64, as recently as 2010, that number was 49, meaning that for every 100 people between 15 and 65, there are 49 people who were who were either under 15 or over 65. By 2019, that number had already gone up to close to 54. So already a 10% growth in a relatively short period of time. And this is happening because the baby boomers are aging. So this big cohort's getting older. We're having fewer kids. And so that combination, the math doesn't work for those of us in the middle, the
For
so-called
sure.
sandwich generation. This is a huge challenge. And so technologies can help us. I'm not talking about medical devices. I'm talking about technologies that are helpful for monitoring our health, for helping us think about what to eat and how much we're eating and how to track it, for technologies that remind us to take our medicines, for technologies that help us to communicate, like the technology we're using right now through video conferencing. Those technologies can make a huge difference in enabling people to age in place and to take the burden off of caregivers, whether those are family or community caregivers, or if they're professional paid caregivers. So that's really what intrigued me, is this opportunity to leverage technology to do at scale what's really hard to do, sort of one caregiver or one nurse or physician at a time.
Yeah, absolutely. And I think it's really interesting because I think, the kind of, as you made the point at the start, that often how a society treats and kind of, thinks about the population and care for the population of older adults in many ways is a reflection of the values of society itself. And that, can differ across the world and, appreciate the shout out of my home country of Australia. But, I think that you're right in terms of like, there are most societies are dealing with the same challenges where there's this kind of, I think you pointed out the truly bittersweet irony of geriatricians retiring, causing a shortage of people to care for them in their retirement. But I think more broadly, kind of that dependency ratio and the shortage of resources to care for an aging population. And I think we're seeing a lot of discussion at the moment about the kind of trend of aging in place and care at home, which in many ways is solving some of the physical constraints of, not necessarily having to have someone in a hospital or having someone in a facility to kind of care for them. But clearly that's not solving for the human capital constraints of kind of an aging population and a higher dependency ratio. How do you think about the role of technologies in that movement of aging in place or care at home? And I guess how urgent is it with kind of the increasing dependency ratio and the increase in the aging population for technology companies to step up there?
Aging is a crisis in the United States. It's a crisis around the world. Some countries like Japan, Italy are rapidly aging even more than we are. Even China is having a huge problem now because of the lack of younger people and the very low birth rate that they have.
For
They're not
sure.
even at population replacement. Their population is already beginning to shrink. Without immigration, the United States would be in an even worse position than it is today in terms of that dependency ratio. So it is really important that we get stuff in place now to be able to care for not just people today, but 10 years from now, when the baby boomers, in 2030, it's actually going to be 5 years from now, that the youngest baby boomers will start turning 65. So there's a lot more of where that came from in terms of the growth of that older population
Mm.
at a time when the working age population is not growing very rapidly. Those under 15 is shrinking. And so this need for technologies to work right away is absolutely critical. And to the extent that we can use technology to extend the reach of physicians, of nurses, critically important. I love making house calls and it's fantastic, but it takes a lot of time. If I can get
Sure.
on a video call and have a conversation with you, that's better than even a phone call, which is still better than having to drive somewhere, especially in Boston traffic, and to find a place to park and all that other good stuff. But it's really enabling us to do a lot more through telehealth as an example of a technology where it's a really great communication technology that allows us to communicate with people, multiple people at large distances at the same time, or one person at a time. Hugely helpful until COVID, vastly underutilized. Now with COVID, it's better, but it's still not optimally used. It's used predominantly for behavioral health. That's been where we've seen the most growth and sort of maintenance of use of telehealth. But for geriatrics, we're still not seeing the growth like we could for being able to use these technologies in the home. Other useful technologies in the home are things like personal emergency response systems, where when you fall down, you push a button, you can get help from a call center. Remote patient monitoring, where you've got the blood pressure cuff scales that can be used to monitor chronic illness that connect to the internet, and then people can watch it from a distance and say, "Oh, Mike's blood pressure is high. I'm going to call and see what's going on." What's really exciting to me there is that these technologies are beginning to merge. So, for example, for personal emergency response systems or PERS, now many of them have fall detection built in. Not
Mm.
have to ask you if you fall in the last 6 months, but when you fall
Yeah, yeah.
down, you don't have to push the button anymore. It automatically sends a signal to the call center to call and check and make sure, because some people, when they fall, are hurt badly enough that they can't push the button. So this is a great step forward in safety. It also turns out that people underreport falls because they're worried that if my kids knew I was falling, they'd force me to leave my home and
Yeah.
move to a nursing home. And so there's a lot of opportunity to use technologies like this, and that acceleration is only going to continue. I mean, I have a smartwatch on my wrist. It has oxygen saturation, heart rate. I could do an EKG on it, falls detection. It has GPS built into it, so it counts the steps I take every day. For people with cognitive impairment, for example, we can create sort of what they call geofencing. So I can be alerted if my loved one with cognitive impairment wanders away from that area for more than a certain period of time. And that's the thing about these technologies is the more they become passive. So I don't have to push a button, but it detects the
Yeah.
fall. Or I only get an alert if my mom or dad who's cognitively impaired has been away for more than 2 hours. I don't have to call them every 2 hours and check on what's going on. The better we are at that, and voice command based and voice interaction rather than having to type or push buttons, the better and more useful that technology is for older adults, many of whom have challenges with vision or with manual dexterity because of arthritis, or in some cases even cognitive impairment.
For sure, for sure. And I guess that's, I mean, obviously having it being used passively is one way to make sure that it gets used and engaged and adopted. And in many ways, I think there's probably a prevailing question here from, to ask on behalf of kind of the audience of, yeah, how do you feel about the idea that older patients don't want to use or don't engage or adopt technology or aren't technology literate? Is that true? Is that kind of a broad brush statement? Is it a stereotype? And particularly as you kind of mentioned, like a few fantastic use cases of technology with older adults. Like how do we kind of wrestle with that issue?
Yeah, so I think it's important to look at the data. Some recent data, I think, from Pew Foundation, from the Pew Project on Internet and Society, found that 76% of older adults over 65 actually have smartphones, which means they can text, they can use apps, and certainly they can use video conferencing, and they can call their kids or grandkids or whoever, or reach out for services, whatever they need, and or use the internet on their phones to access services through the internet, through the web. However, when you look at those who are over the age of 80, that number drops from 76% to 17%. So when you think about older adults, they're not a homogeneous group. There's a lot of diversity, even within those between 65 and 80. There are a group of them, probably 20%, that don't have smartphones. And even within that 80% who do, not all of them are using it equally well for as many things as they could use it for. And so it's really important to think about in geriatrics, it's always about the population, but then understanding the needs of each individual. So
Sure.
if the stereotype is most older people don't have technology, don't know how to use it, clearly that's not the case, at least for people under 80. But even some of those folks over 80, even if they don't have a smartphone, they text you. Like
Yep.
texting with I just text with my father all the time. And this is something that was easy for him. He was in his late 70s, not a problem at all. And I
Yep.
think as we continue to age as a society, you'll have more younger older adults, people who are just 65 or 67 or whatever, who are used to using all kinds of technologies. And we all learn to use new technologies all the time. So we're learning
Yep.
to use my smartwatch I didn't have 5 years ago, right? So that has changed the way that I think about, am I standing up? Am I getting my steps? All the rest of it. I expect that evolution will continue over time.
Yeah, absolutely. And I even think about that same data that you mentioned when you look at like pre-COVID versus post-COVID, the change in adoption and use of smartphone and technology, from 2019 where it was sitting kind of about 50% to now that 76% stat that you mentioned. I think there's a very, that is far more than the number of people who, aged into the 65-year-old age bracket. And so it's very clear that there are certain triggers, like being able to call your grandkids or your kids on a FaceTime call because you can't go see them in person, that have driven the adoption beyond just that kind of aged progression. But I think you're right, like absolutely right to call out that, like, for, that people over 65 are not a homogenous group. There's people who are highly tech literate, there are people who have low levels of tech literacy. And so it's about finding probably the right technology, but also the right medium to, engage them. And, for some, that might be the latest and greatest, Apple Watch with, ECG detection and blood oxygen saturation and everything else. For others, it might be something that's more passive. And I guess the kind of the big buzzword there is kind of personalization and finding kind of the right technology for the right person at the right time. Obviously, that is challenging in an older demographic where there may be much more variance in kind of tech literacy, health literacy. Um, how do you think about kind of tailoring care and personalizing care for such a varied population, and how is that changing? Yeah, I think we've all kind of seen the kind of Cambrian explosion of AI and large language models over the last couple of years, and that, in delivering highly personalized in a really, interactions in a really scalable way. How do you think those type of technologies are changing that personalized approach for older adults?
Yeah, so I think in geriatrics, as a geriatrician, the only technology we have is assessment. So think about a cardiologist, they can do cardiac catheterizations, they can do ablations, they've got lots of different tools that they can use, procedures. Our strength is being able to comprehensively assess the health of an older adult. And that is the only way to really understand what someone needs and what they can do. So being able to understand what are their health related needs, what we call the biopsychosocial model of care. It's commonly used in family medicine, but basically understanding physically what is their health like? Do they have needs? The psychological model, obviously critically important. And then the social model, which includes things like their community, how they eat, their mobility in the home, mobility in the community, mobility in the world. Understanding sort of how they live their lives is critically important. And AI does offer this opportunity to scale because if you've ever had to fill out, a typical form when you go to see the doctor, it is tedious. It is unnecessary because 15 other people probably asked this of you in the last few months, and it's probably in the EMR, electronic medical record already. What's interesting is AI through a chatbot can actually interview you, say, "Oh, Scott, tell me about your health. What are your health problems? What medicines do you take? Have you ever been in the hospital?" We can just have a conversation, and that conversation can not only be recorded, but it can be analyzed by the AI. So it fills in the form for you. And you don't ever have to think about doing that again. It's someday anyway. And you can
Sure.
actually create a digital twin, which would actually have you and your characteristics and mirror you so that people would even have to ask you at some point. They'll be able to query what's in your digital twin and not even have to bother you to ask any of this stuff. It's sort of like when you think about where this can go, AI represents huge opportunity. I think it also represents huge challenges. Trust but verify. I don't think the large language models are still quite where they need to be. And so when I
Sure.
use ChatGPT or Claude or whatever your favorite, I asked one a couple months ago, what was the score in last night's Red Sox game? And it gave me the score from 3 years before. I checked
Yeah.
again because I said, well, who are they playing? Because I knew the answer, but didn't get it right. A few weeks later, I
Yep.
asked the same question. It got it right. So the crazy thing is these things are constantly getting better. That's the real strength of AI. It's constantly learning and improving and learning and improving. And so for now, we're still in the trust but verify phase. I also did a query. I was doing some research on something, and it actually sent me a list of papers which were inaccurate. They had just chopped
Yep.
up authors from similar papers and journals with similar titles and mushed it together. When I went to actually pull the article from the journal online, I couldn't find it because the article didn't actually exist. My guess is that's been fixed. This was again a couple months ago, so
Yeah, for
it's
sure.
constantly getting better. As it gets better, we're going to need to think about how to use it. We're going to need to be careful about how to prevent the biases that are built into the data that form the intelligence of the AI, those biases carrying over to human beings. So this is the
Yep.
issue with data sets that only have males or only have females or only have people of a certain skin color. All these, they're dermatology databases, for example, where they don't have people with dark skin. And skin
Mm.
lesions can look very different in those populations. Our atlases don't always have that, which means that if you're training your large language model on that kind of atlas, you're missing a visual model. You're missing lots and lots of important data about how to make diagnoses for dermatology. And so you need to be careful about the biases that sneak in, and we need to think about who's going to watch for that. How do we anticipate that? How do we test these things? Who's accountable when we find that there are these biases baked in for making the changes or for stopping the use of these models because they're biased and they're going to lead to negative health outcomes or worsen health equity or whatever the case may be. So it's really important that we think about the governance of AI even as it becomes more powerful, actually, especially as it becomes more powerful.
For sure, for sure. And I think, yeah, it's important to recognize that as much as it sometimes feels like magic, it isn't magic. Like it is only as good as the data set that we are using to build the models. And I guess the kind of, you mentioned a few things that kind of hint at some of the social determinants of health and the biases that maybe exist and drive worse health outcomes generally. Um, there's been a lot of focus on social determinants and a lot of discussions about social determinants of health, and it'd be good to kind of get your perspective, particularly as we think about older populations, the importance of addressing some of those non-medical needs like transportation and food access and some of the technologies you've seen that have been successful in that area, particularly given your experience at Uber.
Yeah, no, critically important. As I mentioned, geriatrics is a holistic discipline. It's the same as family medicine, primary care, internal medicine, pediatrics, even palliative care. And based on the idea, like the World Health Organization says, that health is more than the absence of disease. So it's actually being able to do the things you need to do to age in place for older adults, which requires being able to access decent nutrition, be able to move about. We talk about activities of daily living, which are things like the basic activities of daily living are things you need to do to stay alive. Can you feed yourself? Can you bathe yourself? Can you get dressed? Can you go to the bathroom by yourself? All of that. Then the instrumental activities of daily living are things like, can you buy your groceries? Can you clean your house? Can you pay your bills? These are the things you need to do to remain independent in the community, and they cross over into social determinants. So if you can't do your own grocery shopping, or if you can't afford your own groceries and no one knows that, it doesn't matter what kind of medicine your doctors have prescribed for you, because you're not going to be healthy enough to actually benefit from those medicines. So it's understanding that health is based on good nutrition, functional status, which is critical in geriatrics and often overlooked. It's much harder to measure in some ways. A get up and go test, or walk, you have someone get up, walk 10 feet, turn around, come back, sit down, time it. That tells you a lot more about that person's health, believe it or not, than even lab tests that we can order, because it's closely tied to your overall level of health and fitness, which predicts mortality and other complications. So technologies that can actually observe people walking, can sensors in the home that can detect a change in your condition before you say, I'm not feeling well. Those, I think, are the huge technologies that we have. They're available today. They're often not used because of lack of business models and a lack of understanding of who should pay for them and how to pay for them. But they're increasingly cheap. So you can put a motion detector in the wall of someone's apartment, and the software can be trained to understand the typical patterns of behavior. So many people get up at night to go to the bathroom. The story they always use is, well, this person said getting up once, they got up 4 times. Maybe there's something wrong.
For
So
sure.
that could trigger an alert, which could have someone check in and say, hey, how are you feeling? Older adults often experience illness and not as specific symptoms, but just they're not as hungry, they're sleeping more, they're sleeping less, sort of very non-specific, vague symptoms of just not feeling good. Well, if we don't ask them every day, how are you feeling, better, worse, same as you were yesterday? This is where having a companion robot, like I've worked as the chief medical officer for Intuition Robotics, they make LEQ. Um, LEQ is there 24/7. It's a conversational sensor, I call it. It can be the check engine light, where if I ask you, how are you feeling? You say, I didn't sleep well last night. LEQ will remember and ask you later, do you think you want to take a nap? Or the next day we'll say, hey, how'd sleep go last night? Because I know you didn't sleep well the night before. And it's constantly also learning your patterns of behavior, your preferences, what you want to do, and whether or not you want to take advantage of things it can offer, like exercise videos, video calls with your loved ones or with your clinicians, trivia games, music, weather, all of those things all in one
Mhm.
place. It can
Yeah.
provide. It can really help people who are isolated or lonely connect with the world and engage in the world in a very, very specific way that they choose and that they manage. And it's all their preferences in terms of how much they do or how little they do. It's been really helpful and successful, and lots of people are enjoying having LEQ as their companion.
Yeah, for sure. And I'd imagine, I mean, obviously tackling social isolation in a big way, which we know is a challenge with many people. I mean, regardless of older adults, I mean, I think loneliness overall is rising, but in particular in those older demographics. Um, yeah, and then I guess, the kind of other thing that we are seeing more and more is, we talk a lot about different ways to engage people and the way that they want to engage people at Perks. And we've always kind of grouped it into extrinsic motivators, things like rewards and incentives, intrinsic motivators, which are kind of like the Duolingo style kind of gamification motivators. And then the third kind of category we talk about a lot is social. And that can mean a number of things. It might be connecting them with someone who is a similar age, managing a similar condition. It might be connecting with their family and care team and almost kind of creating accountability that way. But I think it is a really interesting and underutilized kind of motivator for change over time and healthcare engagement is the benefit of connection and community. But it sounds like the kind of LEQ devices, in many ways, like is providing that kind of immediate day-to-day kind of engagement as well.
Exactly. And what's really interesting about LEQ and almost a little surprising, first of all, it's not a substitute for human beings. Let's make that really clear. It's not a doctor that's going to diagnose you. It's not your caregiver that's going to give you a hug. It's not able to do many things that human beings do for each other, but it can augment companionship. And what's really interesting is people form relationships. Like they talk to LEQ like they would talk to a human being.
Yeah,
They have expectations like they would have of a human being. The designers of LEQ intentionally did not give it like a face. It has a humanoid kind of shape, but it doesn't have a face. Some people
sure.
will put eyes, they'll tape eyes on because
That's
they
great.
feel like LEQ is their companion and they want that sort of human anthropomorphization of the robot so it feels more like a human companion. But that's something that we really want to make clear is that it's not a replacement, it's not a substitute. We didn't want people to think it was a human being.
For sure, for sure. That makes a lot of sense. Well, I think we're kind of running up on time. I had one question that I think has come through from the chat, which was, um, I guess where to get started. I mean, if you're a healthcare leader looking for a place of, kind of how do you kind of start biting off the kind of huge challenge of you delivering technology to improve outcomes for older populations? Where is kind of the logical place to start or the logical question to start with, I guess?
So I think it goes back to the assessment. So what is your population? Who is in your population? What do they need the most? So find the things, the use cases that where you're going to add the most value. There's always this sort of 2 by 2 square of life where things that are easy and things that are hard and things that are have the most impact versus less impact. Find the things that are easy and relatively easy to start and easy to implement and also have a high impact. That's really where you should start. And that depends on the population of folks you're working with and what problems you're trying to solve. So if you're trying to deal with distributing food to people, you asked about Uber a second ago. The great thing about Uber is it isn't only transportation anymore. It's also food delivery. It's also medication delivery. It's over-the-counter goods from pharmacy delivery. So it's really, if you can find those things, those solutions that are easy to start with and impact is high, and where you can do more than one thing, if that's possible, those are the winners, and that's where I would start. Is that simple analysis of problem you're trying to solve, what's easy, what's hard, what's high impact and low impact, and find those things that are high impact, easy to start with, and begin with that.
Fantastic. Well, appreciate we're kind of 1 minute over time, so we might wrap it there. But Mike, really appreciate you taking the time to chat with me today. And I think also big thank you to all the attendees who jumped on board as well. Great to have you all here, and definitely feel free to reach out to myself or Mike if that's okay for me to volunteer if you have any follow-up questions. But yeah, really appreciate it and have a great rest of the day.
Thank you, Scott. Really appreciate it. Great to be with you. And thanks to the audience for joining us. It's been my pleasure.